I think we're pretty much ready to go live first rather than any lecture. So let's join up with Sivakumar in Chennai.
Shaq, can you hear me? I'm able to hear you very well.
Good morning, Shiva. Can you? Okay, we can hear you and see you.
Yeah.
Very well. I'm joined on the stage by Mario Carminati and Zaid Amin, and I'm just looking for Todd Brinton as well, if he's somewhere.
Okay.
You can join us. Yeah.
I hope you had
one of the moderators as well. Okay.
I hope you had a good day yesterday. Now we will give a brief introduction about the patient. Can you start the PowerPoint? Go to Elevo.
Hello. Hello. It's coming? Yeah. Good morning. This patient, 28 years male, diagnosed to have VSD with severe PH at the age of 5 years and underwent VSD surgical closure at that time. He was relatively asymptomatic till 2013. In 2013, he developed effort intolerance and syncopal attacks. At that time, he is detected to have persistent severe pulmonary arterial hypertension and started on tadalafil, ambrisentan, dieter, and milrinone was recently added due to worsening of symptoms. Syncope, fatigue due to hypertension, and anasarca. Now he is in NIH class 3 for past 1 month on milrinone infusion continuously. On examination, weight is 53 kg, pulse rate is 90 per minute, regular. Blood pressure is 90/60 in right upper limb. On cardiovascular system examination, JVP is 5 cm above the clavicle with both A and V waves are prominent. 3/6 pansystolic murmur in the left lower sternal border, increasing on inspiration. Wide split second hand sound and P2 is loud. Constant pulmonary vascular ejection clicks. Now coming to the ECG, there is complete right bundle branch block with heart rate of around 80 per minute, sinus rhythm, right atrial enlargement, PR interval 200 milliseconds, QRS axis around plus 210 degrees, extreme right axis deviation, R wave in V1 is around 25 millimeters. On chest X-ray, it's situs solitus, levocardia, cardiothoracic ratio of around 75%. Main pulmonary artery is prominent, both RA, RV enlargement, and there is peripheral pruning of the pulmonary vasculatures. Now on echo, there is congested IV, dilated RA, and severe RV systolic dysfunction. RV free wall strain is around -12%. Severe TR with RVSP of 88 mm of mercury. Moderate PR with peak gradient of 48 mm of mercury. Not playing. Now summarizing the echo finding, IVC is markedly dilated and congested. Systolic flow reversals in the hepatic veins. Dilated right atrium and measuring around 8 cm. Tricuspid annulus is dilated to 45 mm. Severe TR. RV fractional area change is around 25%. RV free wall strain is around 12%. Severe RV systolic dysfunction. Mild to moderate pulmonary regurgitation. VSD patch is seen in the outflow septum. No residual flow across the VSD. Now cardiac catheterization, SBC SpO2 is around 39.5%. PA pressure is around, systolic is 86 with mean of 35 and aortic pressure is around 90. So PA is almost systemic. And QS index is 1.53, so cardiac output is low, and PVRI is around 13.18. Now final diagnosis, post VSD surgical patch closure, persistent severe pulmonary hypertension, RV systolic dysfunction, systemic venous congestion in NYHA class 3, currently on millinol infusion and oral pulmonary vasodilators and syncopal attacks. Now our plan is to put a AFR implantation.
Yeah, can you hear me, Shaq?
Shiva.
Yes.
Yeah, we can. I've got Zion who wants to ask you a question.
Hey, this is Zaid. How are you?
Hi, Zahid. I'm fine. How are you?
Can you hear me, Shiva?
Yeah, I'm hearing you very well.
Hey, very well, thank
No, I have
you.
to do that.
Okay.
Okay, I have to do that.
Great.
You,
Hey,
you,
listen, the stats are 89% baseline,
what's that?
right?
Hello?
You said the saturations are 89% baseline?
No. Baseline saturations were normal, around 98%. There was no PFO that was shunting. During the time of the previous cardiac catheterization, due to some sedation, his saturations were 89. But in room air, when he is in an awake state, it is 98.
Okay.
Okay, so tell us how far or what we've got.
See, the problem for him was he was operated in early childhood, and he has severe pulmonary hypertension. He was scheduled for a heart-lung transplantation. However, his functional capacity was not so bad, so he is waiting to get a transplant. In the meantime, whenever his blood pressures go low, he gets sort of mild near syncopal episodes. Last almost 1 month, he has been on and off on milrinone infusion. He has significant anasarca, but currently we have controlled with a lot of diuretics. Today's hemodynamics were, we were having an aortic pressure of around 100 systolic. At the same time, his pulmonary artery systolic was also 100. And he had an RA mean pressure. We had diuresed him well. RA mean pressure was around 8. He is right now the issue that we are finding is we are planning to get a transeptal, and for last couple of minutes I have been trying, but the atrial septum is, you can appreciate the echo. Can you take away my picture, take away my photo and show the echo? Can you hear me? Because remove my photo, remove the camera and show the echo. Yeah. So the basically the left atrium is sort of squashed out.
To do the transeptal under echo control.
Under
Mar is taking. Are
yeah.
you planning to do the transeptal with fluoroscopy and transthoracic echo as well?
Exactly.
You're not going to use transesophageal echo, right?
No. Actually, we are not given any sedation for him. We just wanted to keep him without any sedation since his hemodynamics were borderline. So I am planning to do the transeptal in the conventional fluoroscopic manner. So the issue that I was facing when I brought down the septal puncture needle for the first time, since the atrial septum is enormously bowing out, I was not able to get show the
Shiva, just a quick question. You don't, presumably, you don't have the radio frequency
no
transeptal system.
No.
Here, the left atrium is very small, isn't it?
Yeah. So the intention is, the moment I enter the left atrium, I will put a 1/4 coronary wire and then advance it.
Shiva, can you locate the tip of this sheet by echo where you are? What position on echo you're at?
Yeah. Subsified, can you show one picture?
Four-chamber view, we can.
Wherever I am indenting, it's on the posterior wall of the right atrium. Yeah, come down on, yeah, correct.
Shaq. Samir here in the back.
Oh, yeah.
You're mentioning radio frequency, but what about even just using electrocautery to the needle, if you feel? It's just a very simple
Show
method.
the tip of the needle, Ramya.
1 second, sir. I'm showing.
Good suggestion.
Yeah, I would agree that we do that routinely by using pulsator, just connecting the electric power and...
Can you see?
What we are seeing is the subxiphoid view and the small left atrium on the top.
You're intending?
Actually, it's very difficult to see the left atrium, which is rather small.
Echo will help you a lot here, since you don't have a radio frequency wire. Help a lot where you're going to poke.
Come to
Commercial flow.
AP view.
This may not be echo.
It's got to be echo. On the fluoro, you could be anywhere with that projection as well as the need.
Yeah, we are in the LA. So,
Sivakumar, are you hooked to pressure? You're in the left.
yeah, no, I have not hooked to pressure. Actually, I had connected to contrast for, can you give that? I'm now advancing a coronary wire.
How did you how did you decide to push the needle? Because I couldn't see anything on the transthoracic echo.
Yeah, we couldn't see, Shaq. Basically, the left atrium was so small. And we probably were pushing the atrial septum against the left atrial free wall.
Finished.
I'm trying to. No, that's it over.
Maybe wrong to say, but a little bit of guesswork.
Educated guesswork.
Yeah, absolutely. Yeah. What's the left atrial pressure?
I'll hook it, Shaq. Basically, I am trying to, I'll show you where I am. You see that I am in the pulmonary vein. Can you appreciate that?
Yeah.
So I will advance my transeptal sheath a little bit more inside. Relax, Amro, relax. Okay, now get me a regular wire. I'll now connect to pressure.
Can you see by echo as well that the wire is in the left atrium?
Yeah.
Can you confirm it by echo as well or no?
Yeah, we'll show you the echo.
Okay.
This is the pressure in the left atrium. Show the pressure in the left atrium. Give me a. So the left atrial pressure is around 2. That yellow line that you are seeing, it's around 2. I'm going to give one small contrast injection in the left atrium to show that. Take your hands out, Ramya. So this is, we are facing the pulmonary vein. I'm taking out the septal dilator, RCA. Shaq, I would like to tell.
With those pressures, are you going to work with those?
Yeah, tell me,
Shaq. Are you going to
Shaq.
work with those pressures or judicious volume donation?
What's your question? You want to, like, some volume?
Yeah, I was just asking, are you going to be comfortable and proceed with those pressures, or are you going to give a bit of volume to raise them a little bit?
Actually, Shaq,
Well,
he's
that has
already,
to be done carefully,
in terms of inotropes, he's already on dobutamine and milrinone before the procedure. And right now, we are we are giving just volume, dobutamine and milrinone. I want amplitude superstiff guide wire. Cut down your pacing and see what is the rhythm now. It's all. In between, he was having some bradycardia, and so we had connected him to. The moment I have the wire.
What was the question there?
Have you given him heparin now?
Yeah, just now given.
And take the pigtail out of the aorta.
Yeah,
Heparin.
sure. Yeah. Get me the transeptal sheath. 4,000 heparin in, no, already? He's around 40 kilo, give 4,000 heparin. Check on whether. Amra, it's getting over, that's it. Relax. You can give some volume, Giri. No sleeping medicine. Volume means some fluids. Show that. Marine sheet. Yeah. Relax.
Oh, they probably thought Valium, I suppose.
No. Okay.
That would be all right.
He's actually from Syria. The patient is from Syria. And he was listed for heart lung transplant in our country for the last few months.
Shaq, do you think there's any benefit or some risk or benefit of putting volume directly into IV versus directly into the left atrium in this case? How would you treat the volume from your standpoint?
That's a good question. I would have thought, I mean, it's got to be very judicious, but I would have thought I'd give it directly into the left atrium.
Perhaps not even treat. Given the amount of inotropic patient, any morning boat would be really bad. It's a vitamin.
As long as we ensure that no small air bubble goes across, then probably we can give it into the LA.
Yeah. So what are you planning to do now that you're in the left atrium? Do you have any idea of the size of the AFR that you want to implant, or what are your thoughts?
The previous cardiac catheterization that was performed, the RA mean pressure was almost 20 millimeters of mercury, and so he was hospitalized for the last 5 days, and we were giving him stiff doses of diuretic infusion. What is this? I want contrast again. So we were giving him continuous diuretic infusion because his liver was pulsatile, he was having a lot of anasarca, his groins were edematous. So we had given him a lot of diuretics. And today morning with all the diuretics, his RA mean pressure when we were starting was around 8, and the LA mean pressure is around 2. So considering that his RA mean pressure used to go very high, I was thinking about using a very small AFR. Normally we put in 8 or 10 millimeter for every patient with pulmonary hypertension, but he was having much higher right atrial pressures. So we were wondering whether we will take a 4 or a 6 millimeter smaller. Is Nick Haas there? Nick Haas, any opinion from Nick Haas?
Yeah, I was just going to ask him, Nick.
Hi. Good morning, Siva. This is Nick. I fully agree. I would go for a 6 millimeter AFR device maximum.
6, yeah. What about considering putting a 4 first and then taking, seeing what is the saturation and then increasing it into a 6? I have a 10 sheath across, so I can always upsize from 4 to 6.
Yeah, this is I mean, if you have all these possibilities and for training and teaching purposes, this is a wonderful idea. I mean, otherwise I would go directly for a 6 and check them. Why is that the case? We had cases with the AFR device.
You have a good pulse oximeter,
hypertension, patients with severe right heart failure, right atrial pressures 20, 25-ish, and we put an 8mm device in, and we had immediate and complete severe desaturation, so we had to take this out again. And in these patients with end-stage pulmonary hypertension, on the word right heart failure, if you make a 6mm hole, looks small, but you have a significant shunt across this. And you may have 1 or 2 or 3 liters across this of minutes, and so you have a cardiac output of 2 and a shunt of 2, so this is severe desaturation. So in these patients you have to be very quite careful.
Our experience so far is around 23 patients with pulmonary hypertension.
Or is this just
This is a little bit experience. There is additional data from a computerized model from the Karolinska Institute, and so in these patients, 4 to 6 is the way to go. And if he has these 2 devices available, he should test one and see, and then use the other if something changes.
Okay.
Yeah.
So Shiva, there's some discussion there, either 4 or 6. So what are you thinking? 4 at the moment?
See, Shaq, right now, at the current moment, the right atrial mean pressure with all the diuretics was around 8 with a LA of 2. So I am thinking, so far I have never implanted a 4 in an adult. The only time that we had put in a 4 was in a very small child with restrictive cardiomyopathy. So if we don't deliver a good cardiac output across into the left side, the procedure is not going to be very useful. So right now, considering the RA mean pressure of 8, I am thinking about using a 6. So this is a 6 now, because the RA pressure was not very high.
Okay.
And right now his saturations are completely normal. And when I was looking at my 10 French Mullin sheath, the external lumen of the Mullin sheath itself looks like it's around 4 to 4.5 external lumen. That means it has already crossed the atrial septum.
Just quickly give us the dimensions apart from the 6mm hole, the disc.
So the hole is 6mm, and we have 14mm disc. And now I will show you on its profile. So this is 6mm lumen in the center and 14mm diameter. And as I speak to you,
Okay, thank you.
I will get it inside. Echo, ready?
go directly with the device?
So one of the things that we have learned is that the left atrial disc alone should be deployed, and we try to avoid the central waist from getting deployed. So now I am coming back on echocardiographic guidance. I am hugging the atrial septum. Eye down. Just collimate only to the device. Ramya's hand should not get in. Collimate. Only to the device. Yeah. So this is the device. So right now, so we are looking at the saturations. Yeah, yeah. Yeah, Shaq, yeah.
Couple of questions. One from Zion is, did you predilate the atrial septum?
Yeah, there were occasions where sometimes if the atrial septum is extremely thick, I have predilated. But in him, the problem that I was having today was each time I was going against the RA free wall. You can see the spillover of the contrast from the right atrium into the left atrium. Can you see that? On the echo.
Yeah.
So
what French sheath have you used to deliver this?
10 French. This is a 10 French sheath.
10 French. Okay.
Right now, he is not on any supplemental oxygen, and we are recording a saturation of around 91 to 92%. You can appreciate the right atrial, put a color on the tricuspid valve.
What is it? Shiva,
Yeah,
if you can hear me.
Yeah.
If you don't predilate, you think the radial strength of the waist of this device is strong enough to uphold it, and that's why you don't predilate the septum?
Yeah, in a patient in whom it's when we are puncturing without much of difficulty, and then when the dilator gets advanced easily, then I assume that we have gone through the fossa valis, and in those cases we just wait for the radial force of the device to form itself. However, there will be most of the time in postoperative patients where a pericardial patch has been used on the atrial septum, and there was also one patient where there was a Gore-Tex patch and we had to puncture. In those patients, I predilate with a Boston Scientific Mustang balloon, which is a high pressure balloon, to 18 atmospheres, and then put in the device. Sometimes even after putting the device, before releasing it, I will again cross with the central fenestration, and I will again put in the Mustang to allow the device to get a maximum memory, recoil its memory. See, right now the saturations are 91 at present.
So Shiva, ask somebody to show us the color Doppler and tell us what sort of shunting there is there.
Yeah, Shaq, the problem about the color is there is a lot of spontaneous contrast in the RA and RV which was given for the contrast echocardiogram. The contrast is staying there because the right ventricle is not ejecting out the blood that was like when we made the initial contrast echocardiography, that contrast is continuing to stay. So it gives a lot of color noise there. I can show you by again a contrast.
You could give a or you could give a little.
You can see the LA-LV filling. You concentrate there. Shaq, can you appreciate the LA-LV filling when I am injecting?
You see it there, yeah. That's much better than the color.
Yeah, actually
What sort of level of oxygen saturation are you comfortable with now? You've got it down to 91 at the moment.
Yeah, normally the saturations go down to around very high 80s to the very low 90s. I am currently I am getting 90% saturation, and I am happy with that. I think I will stop here. It's varying anywhere between 90 to 91%.
Nick, would you be happy with that? Or?
Yeah.
Yeah, I think this is a
considering that this right ventricle is so much dilated, right ventricular function is so low. He is on dobutamine and milrinone during the procedure right now to maintain his pressures. I will be happy to stop here because he is also not from our own country. He's traveled a lot of distance. I don't want him to have too much of desaturation. Right now it's 90. I'm happy with this number. You're all right?
What is the pressure now?
What is that?
Pressure.
The blood pressure is shown there. That red color line, it is around 85 by 57 with a mean of 67. Make the hemodynamics bigger. Yeah, I can show the en-face view of the device now. Show the Arevo Cordal. Yeah. No, call him it. Keep only the device. Yeah. Now go en-face further. Further Arevo. Yeah, I'll take out the
increase in systemic pressure as compared to before putting the device in.
The systemic pressure is. It was in and around the same level, Mario. It is not a dramatic increase. I would say now it is touching 90. In your screen, just below the fluoroscopy, what you are seeing smaller is the hemodynamics. Change the color to yellow or something. That red is not visible at all. Yeah.
So how do you decide, going back to Zaid's question about pre-dilating the septum, how do you decide that the 6 millimeter fenestration or the hole that you've got is 6 millimeters and not less?
Actually, sometimes we calibrate with the catheter. You can appreciate in this picture the fluoroscopy. I have a 5 French pigtail which is about 1.7 millimeter, and it looks like it is at least more than 3 times. Can you appreciate that? I'll show you adjacent the pigtail and the hole. It's roughly by eyeballing. Of course, I can make some measurements also. Can you make a measurement of the pigtail and show us what is the lumen? Just measure it. The blood pressures are around 85 to 87 systolic. He's not on any pacing right now, no?
No, switched off.
Okay. Actually, what was happening, he was getting bradycardia during the procedure. So we had to pace him for some time. Yeah.
So if that's saturation is 90%, 91%, the hole's widely open. So are you planning to release the device now?
Actually, right now it is around 88 to 89. I think that transverse diameter was a little larger, but I would say, Shaq, by eyeballing it somewhere around 5 millimeter, the hole. So I am right now with this level of oxygen saturation, I am happy to release the device. Nick, what do you feel? Nick, can you hear me?
Fully agree. Yes, I can hear you. I fully agree. I would release the device.
The release process is similar to any other like fibula, the regular Occlutech devices. Come to AP view. According to the protocol, what we do now is again a oximetry run for finding out what is the cardiac output. One thing we forgot to tell, the pro-BNP level was around 1500, 1400 or something. The pro-BNP as an indicator of right ventricular dysfunction. Overall, he is remaining stable. We are not given any sedation. Saturation varies somewhere between 89 to 90% now. He is not on any supplemental oxygen. Be relaxed, all are fine. Okay, everything is fine.
The antiplatelet or anticoagulant protocol afterwards?
The antiplatelet protocol, we give aspirin and clopidogrel for 6 months, two antiplatelets. 6 months later, there is a protocol repeat cardiac catheterization to again assess the cardiac output and the quantum of right to left shunt based on oximetry. And at the end of 6 months, then we stop the Plavix and continue only with aspirin. And we have not stopped any patient aspirin has not been stopped in any patient except one where there was a hereditary hemorrhagic telangiectasia, Osler-Rendu-Weber syndrome associated PAH. She also had frequent menorrhagia, and we had to totally take her out of all the antiplatelets. Otherwise, all the other patients are on aspirin after 6 months and aspirin and clopidogrel for the first 6 months. Pulmonary vasodilators, currently he is on ambrisentan 5 milligram 2 times a day and sildenafil, and those things will continue.
Shiva, Oliver wants to ask you a question.
Hi, Siva. It's a nice case. Now, let's say in 6 months' time, when you see that the cardiac output is not improved, can you make these bigger or can you make them smaller? Especially if the patient has severe desaturation after you put the thing in.
Yeah. Is it Oliver?
Yes.
Okay. Yeah, Oliver, we have not. We have not had a necessity so far to close the AFR in any patient. However, we have been thinking about it, and we thought that an ADO2 device of 6 millimeter, 6.6 ADO2 probably will be able to close a hole of around 8 AFR. We have never had an opportunity so far to close AFR because all except one patient were doing very well. One patient had a mortality. However, that was she was very fulminant right heart failure, and she succumbed about 10 days after the procedure due to persistent both the combination of desaturation, severe right heart failure. All the other patients are pretty stable with the right left shunt. So we have never thought about closing, but I assume that a 6.6 ADO2 will be easy to close.
Yeah, no, I don't doubt that you can close it, and the ADO2 is probably the best device for it. But the question was, can you make it bigger or can you make it smaller without closing it?
Again,
can you stent it, make it bigger? Possible.
It may be possible. In one of the cases, we were thinking about trying to make it smaller, that completely on another indication. where we had put in initially a 10 millimeter AFR and we wanted to reduce it, and we were thinking about putting in a 6 millimeter long device into the 10 millimeter medium sized device. This device comes in 3 different sizes. One is 2 millimeter width, and second is 5 millimeter, and third is 10 millimeter. So we were thinking about putting in a smaller 6 millimeter into a previous 10 millimeter hole, not in the atrial septum but in some other location. I'll tell you, it was across the pulmonary artery band which we were trying to make it smaller. And in that cases, however, we had a difficulty in getting the large sheath across the fenestration, and so we did not succeed in getting a smaller AFR through a larger AFR. I think your question on increasing the size, it is possible by possibly stenting it out, or we can, if there is a sufficient atrial septum adjacent, we can probably puncture again the atrial septum just next to this AFR and put in another AFR at the side of this. We have not had an opportunity to do that so far.
Last question and a brief answer. So who's that up there? Go ahead, press your microphone. Press the button.
Shiva, good morning. Dietmar.
Oh, Dietmar.
Hi, Dietmar.
I appreciate your case very much. I want to ask, because the auditorium have to know the differentiation between the patient with a right atrial pressure maybe above 20 and patients with a, let me say, normal right atrial pressure, and where you improve only the exercise, not the acute situation. So I think it is necessary to differentiate a patient between, with a right atrial pressure of more than 20 maybe, and the other one. So the 20 millimeter of mercury right atrial pressure needs maximal 4 or 6 millimeter penetration, what we know even from the front circulation. Otherwise you have a very huge desaturation. My question is, how many patients you have treated a lot with the device now? I have only do it by ballooning. And in one we have had a big hole because it was a patch what we did dilated, and that was the need acutely to close the interatrial septum again. How many patients have had in your series right atrial pressure above 20?
Yeah, there was one single patient who had a right atrial pressure of 19 millimeters of mercury.
Bit short of time, so brief answer.
Yeah, 19 millimeters RA mean pressure, an elderly lady of around 60 years. We put in a 6 millimeter AFR. She had too much of desaturation. Now coming back to the indications for balloon atrial septostomy in pulmonary hypertension, more than 20 millimeter RA mean pressure is a contraindication for doing a balloon atrial septostomy. So if you go by that count, 19, 20 and all are probably not good candidates for this technology, because the amount of desaturation that we anticipate is quite profound in those patients. The only patient where I had the highest RA mean pressure of 19, she was the only person who succumbed, but she was also morbid with anasarca, RV dysfunction. She was continuously on inotropes even prior to the procedure. And she was elderly also. She was very old. She was close to 60.
Yeah. Thank you.
Let's start with the session.
Yeah, thank you, Shaq.
All right, we'll see you later on. Well done. Congratulations.